You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is October 13th, 2023. Our topic is Biologics in Asthma and Allergic Disorders, presented by Dr. Salmon Aljubran. He is an assistant professor of pediatrics at University of Missouri Kansas City School of Medicine and is the associate program director of Children's Mercy Allergy and Immunology Fellowship Program.
This is Dr. Aljubran. He's our esteemed assistant program director at Children's Mercy and University Health. He has areas of interest in allergy and immunology, urticaria, angioedema, drug allergy, and food allergy. And today he's here to talk to us about the biologic agents in asthma and other allergic disorders.
Thank you, Shan. My name is Salmon Aljubran. I'm faculty at the Division of Allergy Immunology, Pulmonary Medicine, Children's Mercy Hospital. And today we're going to talk about an update in biologics in asthma and other allergic disorders. Disclosure, none to disclose today. So the only thing that I wanted to work today or change what you used to do, that we're gonna try to navigate through clinical vignette or scenarios to help us understand which biological agent is really appropriate or most likely the best option for our patient. And I came up with about 6 scenarios that we can discuss toward the end of the presentation, and hopefully by the end of the presentation we'll be able to find the best biological option for these patients. So the first patient is a 7-year-old female, a history of moderate severe atopic dermatitis with a history of uncontrolled asthma with multiple hospital admissions due to asthma flare-up. She's been in combo therapy for the last 1 year. She had a workup included CBC with differential that showed her eosinophil count of 600 cell per microliter, total IG of 2000 international unit per ml, with positive skin test to dust mite. And she was seen by local allergists who recommended starting biological therapy. And by the end, we'll discuss the options available. Second scenario would be a 49-year-old female with a history of chronic spontaneous urticaria and controlled moderate asthma. And the next step was biological agents, and we'll try to explore which one is a good option for her. The third scenario would be a 10-year-old male with history of AUE, sinusitis, atopic dermatitis, and uncontrolled asthma. The fourth scenario would be a 45-year-old male with history of uncontrolled severe persistent asthma on high-dose combo therapy with negative aeroallergen panel with absolute eosinophil count of 100 cell per microliter. And the fifth scenario would be a 39-year-old female with a history of chronic rhinosinusitis with nasal polyposis, the status post-surgery, with history of uncontrolled severe asthma. And she's an ER nurse, and she was evaluated by an allergist, and they discussed the option of biological agents. The last scenario would be a 57-year-old male with a body weight of 150 kilograms, with history of frequent admission to the hospital due to asthma symptoms, and patients already on Omalizumab for the last 1 year, but he continues to have uncontrolled asthma symptoms. So we'll try to navigate this scenario, and we'll be, hopefully toward the end of this presentation, we'll be able to find the best biological agents for these patients. So asthma is a chronic inflammatory disorder and characterized by frequent the wheezing, coughing, or shortness of breath associated with bronchial hyperresponsiveness and reversibility. It affects maybe 339 million worldwide, with about 17 million adults and 6.3 children in the US. Majority of the time, asthma symptoms will be controlled with the standard stepwise approach, but unfortunately, maybe 2.5% kids or up to 10% adults will have severe asthma that they need more than the standard or the stepwise approach to control their asthma. So asthma is a complex syndrome, to be honest with you. We, in the past, thought it's a real simple disease. It is not. It's a complex disorder characterized by variable and recurrent symptoms, airway obstruction, and the thing we mentioned earlier, bronchial hyperresponsiveness, and underlying inflammation. The interaction of these features of asthma determines the clinical manifestation and the severity of asthma and the response to treatment. So asthma is really complex heterogeneous disorder with multiple phenotypes. And the more you know about asthma, the difficult become to define asthma. And as you can see here, this is just a simple illustration or cartoon to show you that asthma can be classified into type 2 inflammation or type 2 high inflammation and type, let me see if you have the pointer here. Yeah, all right. And you can have the non-type 2 or like type 2 low inflammation. And the cascade starts with an allergen or virus or chemicals interacting with the epithelial cells in the lung, and then that will trigger a cascade of a lot of inflammation, starting with TSLP, and then with all these chemokines and cytokines. There's features that certain interleukins like 4, 5, and 13 on eosinophils as the feature of type 2 high inflammation. The neutrophilic or the interleukin 25 or other interleukins could be the feature of the type 2 low inflammation. So asthma can be controlled, and controlled difficult to treat or severe. And controlled asthma includes one or both of the following. You get a poor symptom control that could be manifested with frequent symptoms or multiple reliever use. Activity is limited by asthma, and you have night awakening symptoms. And this is the first criteria, plus or frequent exacerbation that's about 2 or more per year requiring oral corticosteroids, or serious exacerbation 1 or more per year requiring hospital admission. So difficult to treat asthma is asthma that's uncontrolled despite using medium or high dose inhaled corticosteroid with a second controller, and usually that's LABA, long-acting beta agonist, or with maintenance oral corticosteroid, or asthma that requires high-dose treatment to maintain good symptom control and reduce the risk of exacerbation. While severe asthma is a subset of difficult to treat asthma, and that is uncontrolled asthma despite adherence with maximum optimized high-dose combo therapy and management of contributory factors, or that is worse when high-dose treatment decreased. And you know there's a subset of like poor asthma control, and that usually has to do with other comorbid conditions, or sometimes the stuff that we always discuss in the clinic about, you want to ask about using inhalers, the technique, because this could be just asthma that's poorly controlled due to other factors that you can really assess without stepping up with the asthma treatment. We are far away from when we started. After we have a good understanding or much better understanding of the pathophysiology or the mechanism of asthma. We started with simple treatment in the 60s with short-acting beta agonists. Now in 2023, we have precision medicine or personalized medicine as an option for some patients with severe uncontrolled asthma. So precision medicine. So I said earlier that 90% of the time, our patients will get their asthma symptoms good controlled with the stepwise approach. And unfortunately, about less than 10%, you have to have personalized med approach. And that's when we have the precision medicine. And it's important for a lot of reasons, because now we're talking about expensive kind of modality treatment, because 60% of cost of asthma is associated or primarily due to medication, and usually it's to do with the patients who have severe uncontrolled asthma. So we can characterize asthma into subtypes. We have the phenotype or based on endotype or genotype, and phenotype is the it's what we see, and it is the interaction between genotype and environment. And the endotype is specific pathophysiology that help us or characterize or affect the phenotype. And after you classify your patient, then you end up having the tailored therapy, and that's what we're going to talk about today. And I said earlier, you have the type 2 high asthma and the type 2 low asthma, and the features that you looked. So ideally, if you have somebody who has poorly or like uncontrolled asthma, you want to do some workup to try to help you to characterize these patients and look for certain markers like CBC with differential until you get a IgE level, or you could do air allergen panel or skin testing and get a pheno level. All these can help you to decide or pick which treatment can be helpful for your patient. I mean, this is just to show you the stepwise management, and this is the GINA recommendation 23, and you can see that step 5, this is where we have the biological agents, including all the 6 FDA approved within the US. That leads us to biologics, because we need to define biologic. It's a substance that's made from living organism or its products and used in prevention, diagnosis, or treatment. This could be drugs, I mean, include antibodies, interleukins, and vaccines. And even if you donated blood, that's considered as a biologics. Most biologics in clinical use are antibodies. So monoclonal antibodies, I mean, the name is give it away. Mono is like one, cloning the same antibodies, antibody that are produced by a single clone of cells, or in other definitions, identical immunoglobulins generated from a single B cell clone. And these antibodies recognize unique epitopes or binding sites on a single antigen. If you're interested in nomenclature, the World Health Organization came up with the INN group that was meant to come up with standardized way of naming biological agents. We used to have 4 parts of the monoclonal antibodies nomenclature till maybe mid-2017. And late 2017, early 18, the nomenclature or the monoclonal antibodies name consists of 3 parts. You have the prefix, which is random and usually up to the manufacturer. You have subsum A, usually indicate the target class. So are you targeting interleukin or something else? And the sim, which is MAB, which is standardized. In the past, so the old monoclonal antibodies that have been in the market before mid-2017 will have subsum B, and usually indicates the species that they get the monoclonal from. So now we have 3 parts, and that's just to make it shorter name and easier. And now we have most of the monoclonal antibodies are human, so that makes sense to drop the other class or the other species. So with the hybridoma technology that was invented back in 1975, and then subsequently in 84, the 2 scientists came up with that technology or our Nobel Prize and helped us a lot. We came along with the options with monoclonal antibodies. The first monoclonal antibodies used to be full or 100% mouse. With advancement in technology, we're able to get maybe only 33% mouse, and that's called chimeric. And then we moved to humanized, only less than 10%. That's include mouse or other species. And now we have full human monoclonal antibodies. And I believe that we in Kola have a lecture about biological agents and the basic science and how that evolved. So I'm not going to go in details about this, the basic science kind of background. All right, so now we have about 6 FDA-approved biologics for asthma in the US. We have the anti-IgE, which is Omalizumab. We have 3 in the anti-interleukin 5 or anti-interleukin 5 receptor group. We have anti-interleukin 4 receptor and the anti-TSLP. So we're gonna discuss each one individually, talking about their indication, side effects, and other features. If you're interested in knowing where these monoclonal antibodies or biological agents work, you can see their location here. But it's a little bit complex, but something for you if you're interested to see. So we're going to start with anti-IgA therapy, Omalizumab. So Omalizumab is a recombinant humanized IgG1 monoclonal antibody that binds to the Fc or the constant region of the IgE molecule. And Omalizumab been in the market for a long time now. So the first FDA approved for Omalizumab was back in 2003, so literally 20 years ago. And Omalizumab binds to the free IgE, so it does not bind to the bound IgE, to mast cell basophil. So free IgE, that eventually leads to decrease in the IgE bound level and eventually decrease in expression of high affinity receptor. And this is very important to know that Fc epsilon receptor 1 is the high affinity receptor for IgE. And then that will lead to decreased mediated release and eventually decrease the allergic inflammation. So Omalizumab has indication in moderate to severe persistent asthma inadequately controlled with inhaled corticosteroid, because most of the studies done with high inhaled corticosteroid and later on the studies got to be done on combo therapy. And the criteria for Omalizumab, you have to have positive either in vitro or skin test reactivity to a perennial allergen. So you have to have positive allergy testing, and you have to have an IgA level of 30 to 1300 international unit per microliter for kids, or up to 700 international unit for adults, or like kids 12 years and above. In Europe, they go up to 1500s, and the studies show that patients either below or higher that level continued or did improve or get benefit from starting Omalizumab. And you have to have body weight between 66 and 330 pounds. So for you to be able to prescribe Omalizumab after meeting the criteria, you have to have an IgE level plus body weight to be able to calculate the dose of Omalizumab. So initially it was approved for 12 and above for patients with uncontrolled moderate to severe persistent allergic asthma. And in 2016, FDA extended the approval for Omalizumab to include children 6 to 11 years of age. So now Omalizumab is approved for patients 6 and above with uncontrolled moderate severe allergic asthma. I think that we'll a little bit talk about Omalizumab. Omalizumab decrease the exacerbation rate, and the initial studies that was conducted with high inhaled corticosteroid decreased asthma exacerbation up to 45%, and Omalizumab reduces the hospitalization by up to 85%. And when they conducted studies with the combo therapy, they noticed that Omalizumab decreased the risk of asthma exacerbation by 25 to 35%. Something to know about Omalizumab, it has a black box warning for anaphylaxis, and the rate of anaphylaxis with Omalizumab is between 0.1 to 0.2. It's very low risk, and that's why the college and the academy had task force committee that came up with recommendation several years ago. That's a little bit long time ago, I should say. And they recommend that the first 3 doses to be given, and the patient has to wait at least 2 hours afterward. And after the third dose, at 4 doses and above, patient need to wait half an hour. With COVID pandemic and the Omalizumab, the company filed for home indication. So now Omalizumab can be given at home, with the caveat that you have to have the first 3 done in the clinic. and there's no history of anaphylaxis or for any other reason, and up to the provider or the physician who's treating the patient, if that's really a good idea to get omalizumab at home, and the patient has to have or carry epinephrine given the risk of anaphylaxis. So majority of anaphylaxis, like 70%, happens within the first 3 doses, and 50% of reaction happens within the first hour. Omalizumab does not affect or does not, inconsistent data about improving lung function test. And there's no much data support the decrease of oral corticosteroid, though omalizumab does reduce the dose of inhaled corticosteroid. This has been old. In the past, we used to talk about omalizumab and malignancy because the initial data was there's possible concern, but with the Excel study, there's no concern. So nothing that we can discuss now with patients. But if somebody bring it up about, hey, is there a concern? There's no clear correlation between omalizumab and increased risk of malignancy. Omalizumab been there for 20 years, so we have, I would say, good understanding of the way it works and potential side effects. When it comes to pregnancy, the FDA says the fetal risks cannot be rolled out, but we have limited reassuring data that can be safe. But by the end of the day, it's going to be each one is different, and you have to discuss the risk and benefit of the treatment. So if you have a pregnant female patient on asthma, you got to discuss who's already taken omalizumab. You'd like to discuss whether it's really the benefit outweigh the risk of continuing omalizumab or otherwise. That's something you have to personalize it and discuss it because each one has different risk factors, and you cannot come up with a clear or single statement that can fit everybody. But it's very reassuring, but it's limited. And by the end of the day, you weigh the risk and benefit whether you can use in pregnancy or not. Moving on to the other class, which is interleukin-5, we have 3 in this category. We have mupirolizumab, rilisulizumab, and they are interleukin-5 antagonists, while benarolizumab binds its interleukin-5 receptor antagonist. Mupirolizumab is studied with patients who had eosinophilia of 300 cells over the last year, or on admission 150. It's a humanized monoclonal antibody against interleukin-5, inhibits eosinophilic inflammation, and reduces the number of eosinophils in both sputum and the blood, because in the early study with mupirolizumab, eosinophilic sputum was the one that used, and then FDA recommended something that can be useful and a little bit more convenient, so we switched to blood eosinophilia. And omalizumab has an interesting story because the history of omalizumab been there for early 2000 when they conducted the studies with IV form, and they noticed negative result given they used it for general patients with asthma, and subsequently trying to understand asthma and phenotypes and going for the eosinophilic phenotype, that what came up with getting the omalizumab approved, and now it's given or approved for patients 6 years and above, and that the extension for the approval was back in 2019, and the initial approval was 2015 for add-on maintenance therapy for patients with severe asthma and with eosinophilic phenotype. So the FDA does not require a special or specific numbers. As long as it's like eosinophilic phenotype, then that will be more than enough. But we gotta understand that mupirolizumab was conducted with patients who had at least 300 over last year or 150 eosinophils per microliter on administration. The thing that we need to know about mupirolizumab, they noticed that there is an increase of herpes zoster infection during early studies, and it's limited data. I don't recall exactly the percentage, was 3 or 4%, but it was there. So now the package insert has the recommendation of vaccinating patients before initiating the therapy 4 weeks, and usually for eligible patients would be the age 50 and above. Mupirolizumab, as any other biologics, it does not induce tolerance. It's or it's not immune modulator. So once you stop the medicine, patient might go back, or the eosinophil count might go back within 8 to 12 weeks after stopping the medication. I mean, this is just showing this is the Cyrus or the Mensa study, and that shows that the Omalizumab does decrease exacerbation rate by 47%, and it does decrease the oral steroid, and up to like 14% of patients were able to be weaned off steroid while taking Omalizumab. So it does help to wean oral corticosteroid on patients who are taking it on daily basis or chronically. Moving on to Risoluzumab, and this is the for now it's the only one that can be given IV. It's a humanized monoclonal interleukin-5 antibody, neutralized circulating antibody interleukin-5, because it's bind to interleukin-5 and preventing from binding to eosinophils. It's approved for as an add-on intravenous monthly maintenance treatment for patients with severe asthma at the age of 18 years old and above. So you have to have an adult patient 18 and above with severe asthma and with the eosinophilic phenotype. And the studies initially conducted with patients who had eosinophils more than 400. So the higher the eosinophil count, the better the outcome or the benefit. It's given IV, so it's really one of the unique features beside Omalizumab. It has a weight-based, so it's 3 mg per kg and given once a month infusion over 20 to 50 minutes. It does have a black box warning, and the risk of anaphylaxis is 0.3%. I mean, there's not much data about whether it decreases oral steroid, but it does decrease exacerbation. And it was noticed that Risoluzumab does improve FEV1. Data with Omalizumab was inconsistent, and as well as with Omalizumab, no much improvement. While with the Risoluzumab, there is a chance, or there is good data that will improve FEV1. Moving on to the last option of the interleukin-5 family, it's Benralizumab. It's a humanized monoclonal antibody against alpha chain of the interleukin-5 receptor. It's got approved for kids 12 years and above with history of severe eosinophilic asthma, and it's given 30 mg sub-Q every 4 weeks for the first 3 doses. Then you can space it out to every 8 weeks. So it is interesting, or has a feature because it can induce eosinophilic apoptosis since bind immediately to the receptor, and it can mediate antibody mediated cell cytotoxicity. It's one of the features of Benralizumab, and it does decrease total use of oral corticosteroid, and even the studies showed that patients who are chronic user for oral corticosteroid can be weaned off up to 50% while taking Benralizumab. It's well tolerated. The same thing, studies conducted with patients who had 300 cells per microliter or greater. And the same thing, decrease the steroid. And moving on, another category is Dupilumab. Dupilumab is full human monoclonal antibody to the interleukin-4 receptor alpha subunit, and by that it inhibits both interleukin-4 and interleukin-13 pathways. It's given initial studies with, this is the initial study with Dupilumab, and then we noticed that it has a great improvement with asthma exacerbation, decreased asthma exacerbation rate by up to 70%. It does improve FEV1, and it does decrease total use of oral corticosteroid, and even patient can be weaned up to 50%. And it has marked improvement in symptoms as well as in lung function test. That's another study, old studies. Okay, and the last agent that we have for asthma is anti-TSLP. The thymic stromal lymphopoietin, or TSLP, is an epithelial cell-derived cytokine produced in response to environmental and pro-inflammatory stimuli. As you remember, with the first cartoon we showed earlier, that interaction between the environment, viruses, or other stimuli with the epithelial cell that end up releasing TSLP, and then that starts to cascade. So it's in the top of the cascade, and it's interesting because TSLP activated the direct cell prime naive T cell to differentiate into Th2 cell. So it does promote Th2 cell kind of inflammation, and it's expressed highly in patients with asthma, and it does correlate with the Th2 cytokines and disease severity. But it works for both, whether you have, and that's the beauty about this medicine, that it works for T2 high and T2 low kind of inflammation. And this is what I'm talking about. This is the level and all this, so black all on the top. And that's why it can help for both phenotypes. All right, and this is a nice illustration by New England Journal of Medicine that does help with asthma exacerbation, and it's given 210 every 4 weeks, and it's approved for add-on or maintenance treatment for severe asthma and children's age 12 and above, and that the approval was back in December 2021. Home versus office. I mean, that was a big deal several years ago, but now we have a lot of options. Most of the biological agents in the US have home indication, except for Risoluzumab, which is the IV and has to be still given healthcare setting, and given the risk or the high risk for anaphylaxis. The rest can be given at home. Omalizumab, I said earlier that since COVID hits, we have home indication, but you have to fit the criteria. If the 3 first doses has to be given in the office, and then the patient should have no history of anaphylaxis, and then the option of refilled home administration has to be discussed with the provider. So now almost all of them have home indication, so it's not a big of a feature as used to be. So algorithm, there's a lot of algorithm can help you to decide, and as we add more biological agents, sometimes certain areas can expand, certain areas, sometimes you see areas like there's no options, but now with the anti-TSLP, we have an option for patients who have or non-eosinophilic kind of phenotype. We have suboptimal responders. What that means, sometimes you start patients, and ideal for all these biological agents, within 4 to 6 months, it is a good time to revisit and reassess whether there's something patient needs to continue or maybe need to discontinue. These are an expensive medication with potential adverse events. So you want to, before selecting the agent, you want to do the job and work and try to maximize the benefit and make sure this is the best option for your patient. Unfortunately, that in reality can be different. Not everybody might benefit from this medication. So you have to ask the question, when should I revisit, or how long should I continue the medicine? And ideally 4 to 6 months is a good time to assess whether this medicine is a good option or maybe not. But sometimes you run into suboptimal responders that the patient a little bit has benefit, but not as expected. So you might extend that for another 6 months. So ideally, within a year, you should be able to cover whether these who are suboptimal responders or not. And if they're not getting better, then maybe you need to consider other options, switch different biological agents, or maximize or change the dose for that biological agents. The factors that you might need to assess is sometimes you aim for asthma exacerbation, and some patients might have 1 or 2 per year. So sometimes you need to wait at least for a year to be able to tell, because based on what your treatment goal? Is it decrease asthma exacerbation? Is it decrease the need or the use of oral corticosteroid? Is it the need to improve their lung function? Or it's an increase in quality of life? So each one is different. So this is like shared decision kind of making process, and you have to identify what your patients need and whether something they can do or not. And we have different frequencies, different doses, so different features. So you want to utilize this feature to help your patient to make the best decision for them. Because if you have patients who's non-compliant, that's going to be an issue, because you're not going to. Non-compliance is not indication to CPAP treatment therapy. You got to address that first before considering an option. But human nature, some patients may feel like I cannot get the medicine, the biological agents every 2 weeks, and it's something more flexible. So you have options that may be given every 4 weeks, or that can be given initially every 4 weeks and then space it out to every 8 weeks. So each one is different. We have other obligations. So you want to take in considerations the patient choices. So you have to bring up the options for your patient, discuss what is the best for them. And unfortunately, by the end of the day, medical insurance, the insurance will dictate which one the patient can get. So you try your best and you apply and see what's out there. But in reality, yes, insurance will dictate what type of agent the patient can get by the end of the day. This is another algorithm for, let's say you have suboptimal responders. You want to assess, is it medication related? Is it like the antibody, drug antibodies? That's something that has to do with because sometimes it's biological agents. You might have antibodies against a drug, and that might hinder the response to it. It is to do with the dosing. Maybe you need to go higher. It has to do with the disease itself. You want to reassess the asthma phenotype, and then start. Maybe you want to consider different biological agents, or maybe it's just patient-related, poor like compliance or other factors. So you have to address medication-related, disease-related, or patient-related factors that might hinder the maximum benefit for your patient. I keep saying it's expensive. Yes, this medication is expensive, so you want to always take in consideration the cost associated with this medication, and that's why you try your best to come up with the best option for the patients. So you want them upfront to get the maximum benefit, because you do want to just keep switching between biological agents, and it takes you at least 4 to 6 months. So you want to make sure that your patient really getting the best care they deserve. With the same thing, give you an idea about how much each of these medication costs. The other, COVID-19 and biological use in asthma, there's no increased risk. So there's a big gap in biological use in asthma. The standardizing the use of biologics, because we need to come up with the criteria for responders and suboptimal responders. So early termination, when do I need to stop? It's not standardized, and each one, and you can see a lot of variation among physician who prescribe this medication, and switching, like how long should you continue this medicine? When do I need to do? Do I need to do any blood work for the anti-drug antibodies? And long-term, what's the plan for long-term? How long should I continue? When do I need to ask the question, is it a time to stop the medicine? Do I need to space it out? So we need a lot of studies to be able to come up with all to fill in or address these gaps. And the cost effectiveness of biological agents, it's really that expensive. So the same thing, which one is more expensive, which one is more suitable for your patients, and there's no head-to-head comparison between biological agents. Sometimes a patient can, the phenotype, you can have like 3 options available for you. So which one is going to be your best option? There's no head-to-head comparison, so it's difficult to tell. And definitely insurance will play a big factor in that when it comes to which one you can use, but you have to do it up front, and you try your best to come up with the best option for the patients. The question of long-term safety, I know that Omalizumab been with us for 20 years. So we have a little bit of some knowledge, I should say, but most of these newer agents, not much, maybe 7 years, some 3 years. So we have variation. So we didn't have much long-term safety data about this. So we have to come up with, or we need to address these gaps so we can help our patients and make sure that we give the patients the best biological agent they can and can get their asthma under good control. And so what next? This little bit of a possible suggestion that what can you do? Say if you have a patient who doing great on one of these agents, and the question comes in: is it a good time to reduce the dose, or do I need to increase the interval? Just give a little bit of algorithm. Maybe you wanna reduce or increase the interval by 25% and then reassess in like 4-6 months out and see if they continue to do well, then go further, or like now they start to have more symptoms and you go back to the same dose or the same frequency. So a lot of questions not answered, but there's a lot of suggestions, and that's why we see a lot of variation among the providers when it comes to biological agents. And hopefully with time and more studies, we'll be able to address some or all these gaps or concerns. Moving on to a different category, we have chronic sinusitis with nasal polyps, and we didn't have clear criteria in the US about when is a good time to start biological agents, and this is going to be based on patient condition. Yeah, something like is it really after having multiple surgeries? Is like one surgery, two, or situation patient does not want to go for surgery. The European has a little bit of consensus that might guide you when to consider biological agents for patients with chronic rhinosinusitis with nasal polyposis, and their criteria that you have to have a bilateral nasal polyps, and they divide these into two arms: history of surgery or history of no surgery. And plus, if you have a history of surgery, then you have to have 3 out of the 5 criteria. If there's no history of surgery, you can consider you have to have 4 out of the below criteria to be eligible for biological agents. And these criteria, you have evidence of type 2 inflammation, needing for systemic corticosteroid 2 or more over the last year, significant impairment for quality of life, you have significant loss of smell, and a diagnosis of comorbid asthma. So that's something you can work with and help you to make a decision which agent you can use. I mean, plenty been studied, but the only one that got approved by FDA are 3 currently, and hopefully in the future we have more. But for now, Dupilumab is the one that got approved back in 2019 with a dose of 300 sub-Q every 2 weeks. Omalizumab got approval in 2020 and has the same criteria for dosing as asthma, so based on weight and total IgE. Omalizumab got approved in 2021 with a dose of 100 sub-Q every 4 weeks, and these are for 18 above, so adult patients with chronic rhinosinusitis and nasal polyposis. Moving on to biological agents in Urticaria, the only one approved is Omalizumab, and you have 2 doses for treating patients with the chronic urticaria. We had the 150 or 300 every 4 weeks, and benefits of Omalizumab appears to be independent of total IgE. So in this situation with the chronic spontaneous urticaria, you didn't need to worry about total IgE, you didn't need to worry about weight, because you have 2 doses that you can use for your patient. And this is the same thing that happens after Omalizumab. This is the studies they conducted with urticaria, and there was an old suggestion that the same concept that because Omalizumab does not induce tolerance with not immunomodulators, so when you stop it, would urticaria come back? There's still a chance, but we know the urticaria usually with time it should get better, so time is at your side, and you have to have a little bit of plan what you need to do when patients doing well for at least say a year. So it's reasonable to start Omalizumab with a dose of 300. Usually with adults, this is what I go for, 300 every 4 weeks, and take some time. You see impressive improvement, or some patients even after first dose. Some patients may need at least 3 to 4 or sometimes up to 6 doses to see an improvement. And that's the thing, that if your patient continues to have their symptoms and there's no improvement, you have to have the hard discussion that maybe omalizumab is not the best option, and then you have to go with the other alternative options that we used to do for urticaria treatment. And sometimes we try, sometimes if like patients doing great, and this patient is really very anxious to stop their medicine because it's a dramatic improvement in their symptoms, quality of life. So they always have the fear, like, I do want to go back to where I used to be. So you always want to address their concern and their anxiety. And sometimes you want to try a little bit to step down approach. If you're starting with 300, then maybe you want to go down to 150, or you want to space it out more often and see if patients start to have more symptoms, you go back to the previous dose or frequency, or if they're doing fine, you start to further down, space it out or decrease it, and monitor the patients. But you have to make sure that patients' anxiety or concerns being addressed, because it's a major component of, especially with patients with chronic urticaria. For atopic derm, you guys had a discussion. Dupilumab is the one that we talk about, and it was approved in 2017 for moderate to severe atopic dermatitis in adults, and then got the approval for kids in 2020. For EUE, the same thing. The only approved biological agent is Dupilumab, and got the approval back in 2022 as the first biological agent approved, and it's indicated for adults and patients, pediatric patients aged 12 years and older. About their weight can be more than 40 kilos with different history or diagnosis with EUE, and it's given 300 milligram with no loading dose. HIE, Landiolumab is the only available for HIE, but this is beyond the scope, but it's out there, approved back in 2018. All right, going back to the clinical vignette, and hopefully we'll be able now to answer the question. So the first case, we have a 7-year-old female with a history of moderate to severe atopic derm with a history of uncontrolled asthma with multiple hospital admissions due to asthma flares-up. She's been on combo therapy for the last year, and workup showed that she has eosinophil count of 600 cell per microliter, total IG of 2000, and positive skin test to dust mite. So which of the following is the best choice? So who would like to, just bring me your thoughts. Let's say omalizumab. Is omalizumab a good option for this patient? What do you think? Any taker?
I liked Omalizumab for this.
Okay, why think it's you like it? Why?
I liked it because it fits in the age range. So I mean, some of these ones we
He's
can't
7,
do.
yeah. So what's
for
the age is like 6 and above, right?
You're right.
So what are the
and
criteria for omalizumab? What are the criteria for omalizumab? You have a
IgE,
okay.
30 to 700.
Okay, but she's 7, so you can go up to 1300, right? Because the 30 to 700 for adult. For 6 and 11, you can go up to 1400, right?
Right. Okay.
So, okay, so you said because you have to you have a moderate to severe persistent asthma, right? And you have to have total IgE of like 30 to 1300, and positive skin test or blood test for perennial allergen, and weight like up to 330, so 330 pound. The thing that you looked at omalizumab really, yes, patients, great. She has possible allergic asthma, but you have total IG of 2000. Would that be is that going to be your first choice or not?
No.
Maybe not, right? Maybe because you're like, because the total, I said, yes, the studies showed that patients even higher or lower than the criteria did benefit from omalizumab. So something to consider, I would say yes, but I would not say this is my first option. So omalizumab, I think about it, but I wouldn't really jump and say, yes, let's start omalizumab. Okay, so let's keep this in aside. So omalizumab maybe not, but maybe you decide to go with it, but insurance said like, well, she does not fit the criteria, then maybe get declined. So even for you, you would like to increase the chance of approval, right, for the insurance, right? So omalizumab maybe at the waiting list for now. Moving on to Omalizumab. What's the deal with Omalizumab?
The age fits.
The age fits, yes, because Omalizumab is 6 and above. She's 7, so yes. She has eosinophilia, definitely she has 600, still within that range. Definitely the higher the better, that's good. So that's something you can consider, right? That's a good option, but think that you always look for other comorbid conditions, right, with the patient. The patient has asthma. Is Omalizumab approved for asthma? Would it help with asthma as well? Because now you have a patient who has asthma and eczema, right? So you want to always take in consideration other comorbid conditions, because if you're going to use a biological agent, you want to make sure it has multiple indications. And this patient has asthma and eczema or atopic dermatitis. So we have two things. So it's good to use a biological agent that will cover both, right?
Will help.
So that Omalizumab, like maybe it's a really good option, but may not be the best option, right? All right, going to Risuzumab. Why you think Risuzumab is indicated or not indicated? What is the deal
not
with
indicated because she's too young.
Yes, thank you. That's out. So up front, Risuzumab is out. Okay, what about Dupilumab?
I like Dupilumab.
Yes,
it's gonna
I like
help
it
the
too,
asthma
right?
and the atopic derm, and you kill two birds with one stone. And she has
Yes.
eosinophilia, and it fits the age. So I'd roll with that.
Yes, I agree with you. So Dupilumab would be our best option to mount with you because it has own indication for the asthma and the atopic derm, and Omalizumab because the total IG was more than or beyond the approved indication, so that might get you in a little bit difficulties getting approved. But still, you can straightforward to say if Dupilumab is not an option, I would jump and use Omalizumab to launch with you. But for this patient, I would go with Dupilumab as my first option. I mean, you always, because see, sometimes you can have multiple options, but you want to maximize the benefit. This way, the patient would benefit not just for asthma, even for the eczema that's not been going on, right?
Right. Why? Like, what is the thing that throws me off about Xolair or Omalizumab not being able to be used if their IG is too high is like, in my mind, I'm like, okay, it blocks IG. So why do we ever care if the IG is too high? You know what I mean? Is it just the way the studies
how
were
do you
done?
how do you calculate Omalizumab? Based on total IgE. So you get into how much you can give.
There's a formula. Dr. Pandya mentioned it and I already forgot it.
Yeah, so there's two things that you need to know before you start Omalizumab. If the patient fits the criteria or qualifies for Omalizumab, you have total IgE, pre-treatment total IgE, and weight. So you have total IgE comes into play when it comes to the dose calculation.
Percentage of FC RI2 plus IG plus FCRI plus IG plus cells of total whole.
Yeah, there's 0.016 mg per kg per international unit of IgE. So there's calculation to do it, but total IG might affect the dose. Will affect the dose, how much you can get, and that you run into trouble with.
So it's just the dosing limitation that results.
The dose would be an issue. Yes, would be dose how much at frequency, and how, because now it's pre-filled syringes, so the option going to be limited and comes in with other stuff, insurance, where they will pay for it and how much you're going to use. So a lot of what if and if insurance approved. So you run into trouble with this. So this one, Omalizumab is really a good option, not ideal, but I would say Dupilumab is a better option for this patient.
Okay.
All right, cool. Let's see this lovely lady. She's 49 with history of spontaneous urticaria and uncontrolled moderate asthma. So what would be the option? Dupilumab, Omalizumab, Dupilumab, or Risuzumab? Who would like to take this?
So would this be Omalizumab?
Okay, and why is that?
Because of these biologics so far, that's like FDA approved for chronic urticaria, it would be Omalizumab, and then she also at least has moderate asthma, but you would still have to meet the other criteria that we talked about. So hopefully I'm assuming she does, since this is the question.
Yeah, so idea just that's Omalizumab, because now the aim of this question is to make sure that you address the comorbid condition. And unfortunately, the only FDA approved biological agent for urticaria is Omalizumab. So now you have asthma and Omalizumab, and let's say Omalizumab is approved for patients with moderate asthma. The rest have severe asthma. Dupilumab has indication moderate asthma as well, but the rest have severe asthma said indication. So that's my driving trouble. But the reason I got this question, just yes, you have to know that Omalizumab is the one approved for urticaria. So I'm treating asthma and urticaria at the same time, right? So that was an easy question. Right? I shouldn't like go in and out and you're done. Not a problem. All right. Let's say in this patient, 45, male, uncontrolled severe asthma, high dose combo therapy, negative air allergen panel, absolute eosinophil count of 100, seen, okay, recommended Biologics. So which one should be the best option? So we have Omalizumab, Mepolizumab, Resoluzumab, or Tezepelumab. So what do you think? Which one would be a good option for this patient?
I'm trying to remember the eosinophil count for mepolizumab that you had, but I was thinking of all these choices, maybe the tezepelumab one.
Okay. So Sai, you have any thoughts? Yeah.
Yeah, I mean, like, with the negative air allergen panel, that would automatically take off Omalizumab because you have to have sensitization to to like a perineal allergen.
Perfect.
Yeah, as Hal said, I think tezepelumab would work. With the patient's age and it stops the TSLP, so it would kind of stop everything. But yeah, I can't remember the eosinophil count for mepolizumab. And I feel like that's probably what you were trying to get at with this question. So
yeah, definitely. So usually the indication for the interleukin-5 family biologic is like 300 over the year or 150 over on admission. So definitely 100 is lower end, so you might get in trouble, may not be the best option. Tezepelumab, it's approved for either eosinophilic asthma or non-eosinophilic asthma, so they have indication for both. So tezepelumab would be a good option for this patient, to be honest with you. So I would go with tezepelumab as my first choice. Resoluzumab is another option, but still, the eosinophils is really very low. I wouldn't go there because usually it had high, like 400. This is the studies. I know FDA does not require specific eosinophil count. As long as it qualifies for eosinophilic phenotype, then it should be okay. But the studies show that, yeah, the higher the better. So certain numbers may be more suitable. So that's why you have to be very diligent when you select these patients. They're expensive, potential side effects. You want to always take in consideration the best option for your patient that might work. Good. So yeah, I would go with the tezepelumab. So we have a 39 female, so with a history of chronic sinusitis, right? Started post surgery, history and controlled severe asthma, and she's an ER nurse. So which agent would be a good option for her? So which one you think would be a good option for this patient? You have Omalizumab, Dupilumab, Benralizumab, Mepolizumab. So this comes to your knowledge with the chronic sinusitis, right? So which one is indicated? That would help you to at least cross one or two out, right? So which one of these is not indicated for chronic sinusitis with nasal polyposis? Has no FDA approval.
Benralizumab.
Yeah, so benralizumab is out because it's the pipeline maybe get approved, but for now we have only three: Omalizumab, Dupilumab, and Mepolizumab, right? Okay, so now we have these. This can be used for asthma and chronic sinusitis with nasal polyps. And which one would be a better option? Take in consideration patient's job. She's a nurse, a ER nurse, so she's working in shifts, so she's busy. She doesn't have time to show up at your clinic, and she wants something remarkably not that frequent. So what would be our option? Is Omalizumab? Because would be a good option for her.
That one's every 2 to 4 weeks.
Yeah, but you know that she has to have the first three shots in the clinic, right?
In the clinic,
yeah. So that's maybe she said like, dude, I don't have time. I need something I can do at home up front. I'm a nurse. I can administer medications. That's not a concern for me. But I unfortunately get my job. I cannot be in the clinic. So Omalizumab may not be the best option for her, right? Because she has to have the 3 first doses in the clinic. And she's like, no, that's not something I would like to do. Now we are having 2 options: Dupilumab or Mepolizumab, right?
I think Dupilumab was the home administration.
Even Mepolizumab has home administration. All of them. Both has home administration. Comes in the frequency. Now comes in the frequency.
No, the
right?
Mepo is every
Yes.
4 weeks.
Yes.
for Dupilumab.
Yeah, so now, see, sometimes you have to take in considerations patient preference as well. I mean, these 3 medication indicated, but patients like my work lifestyle cannot permit to get in your clinic. So that's why you have to discuss and your patient and see, you give them the options, but they can pick which one they can go for. All right. So this is easy. 10-year-old male, history of EUE, eczema, moderate, uncontrolled asthma. Which would be your best option?
Dupilumab.
Dupilumab?
You have
Yes,
EOE,
right?
atopic derm, and your asthma.
Yeah, and EUE. What's EUE? Which one only approved for EUE?
Dupilumab.
Dupilumab.
Uh-huh.
Yeah. Right? Because the patient has history of EUE. That's the idea that the only among all these biological agents, the one approved for EUE treatment is Dupilumab, and it does help with eczema. It helps with asthma. So yes, Dupilumab is the option.
Are they working on
Hey,
getting anything else approved for EOE?
No, I mean, working on, yes, but I would say which one approved now, like which one is approved by FDA?
Yeah,
The only one is
yeah.
Dupilumab. So
Right.
you've seen a patient in your clinic tomorrow, what option can I go for,
Dupilumab,
right?
Yeah.
Yeah, I'm going to something that you have to, by tomorrow you can use and work with. All right, so say you have a question?
Yeah, I mean, obviously, like even like for that question, I'm like, what makes, I mean, if the patient only had EOE, you couldn't do Dupilumab because of the age at that point. But like because of the other stuff, you can do Dupilumab at that age.
Yes,
Does
good
that
job.
question make sense?
Yeah, definitely. So that's a little bit tricky because you might get in trouble because of the age, right? Because it's 12 and above. But that's something you can ask, try to, because unfortunately there's no other option. Tislelumab is something for at 12, and Rizulzumab 18, that's out. But Dupilumab is our best option. Is it gonna be something that you might fight for? Maybe. So sometimes you can discuss with the insurance, and you might give an exception because the kid is 10-year-old, maybe almost 11, so almost 12. So it's something you can work with. So sometimes you have to take consideration other factors. But the best option would be Dupilumab because yes, you think this is going to be our best fit. With age, a little bit tricky, but you can go for. Otherwise,
Perfect.
yeah, because what you can, because they say you know that the patient has EUE, right? But what you're gonna go for is the either eczema or the asthma. So we have the other
To get it
indications
approved,
that can,
yeah.
and this way you're gonna be covered. But so you're asking for something covered for eczema and asthma, and EUE is a bonus in this situation because if you go for EUE, may not be approved because of the age, but if you go for eczema or asthma, definitely gonna get approved, right? I mean, definitely, but interest has maybe different opinion. Does that make sense?
It does, boss man. Appreciate it.
All right. So this last question, I guess. So 57, male with body weight of 150, history of frequent admissions, not controlled in Omalizumab. So what you need to do next? Continue with Omalizumab for another year, Dupilumab, Rizulzumab, or Tezepelumab?
Then 330 pounds or something, right?
Yeah.
So he's too heavy for Omalizumab.
He's in the upper limit for Omalizumab, but it's still okay. But he's currently has already Omalizumab, and he's been taking the medicine for a year, and he continues to have symptoms. So you did not really achieve much. So do you need to continue for another year with the same medicine?
No.
No, so I would not be my first option, right? I would say, yeah, I would not continue. I would consider maybe another medication.
You didn't mention anything about like eosinophil counts. So I probably wouldn't do like Rizulzumab.
Yeah.
Dupilumab. I mean, I guess you could, but I'll probably go with Tezepelumab again. I mean, for that one.
Yes. See, now this is the thing that you want to characterize your patient. So this question serves two purposes. First, well, you did need to continue medication that's been a year out and nothing been achieved. Your goal was not achieved, right? And then the second option, okay, now what option I have? You maybe want to do the disease or modification kind of factor, like, okay, does this patient has eosinophilia? Because now I need to take in consideration, is he eligible for other medication, right? So you need to do the workup for this patient. Because if he does eosinophilia, then maybe you want to do something from Dupilumab or Rislozumab. If he does not fit the criteria, then your best option would be Tezepelumab, right? And the other thing, this one of the other features, like say you have somebody who has like in the obese range or the heavy side, right? What medication can be weight-based? Which one of the medication be beside Omalizumab? Which one can be weight-based? It is Rislozumab, right? So this is another feature. Maybe if because with the other medication you have fixed dose, and maybe that's not enough for this patient. So maybe Rislozumab based on weight, you can go up higher because like 3 mg per kg. So maybe the patient needs more than medicine. So that's another feature for Rislozumab because the weight may be good, but before I do that, I need to make sure that the patient fits the criteria. So now we need to go back and think about the endotype characterization of this patient or the phenotype, and then you can decide which one can be the best option for this patient. If he does have or does he fit the phenotype eosinophilic, then Rislozumab would be a good option because I have the luxury of weight-based kind of dosing, so gonna be my best option. If no, does not fit, then Tezepelumab may be our best option for this patient. So the idea is that you want to reassess your patients and make sure, because sometimes for what reason he has allergies, he fit the criteria Omalizumab, and this been a long time ago, and did not get the blood test to see whether it has eosinophilia or was not meant to look into it. So maybe that's something you go back and revisit before considering the second or switching to different medication. All right. Okay, cool. I think we need to stop here.